This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffy, who is a paramedic and communications professor.
Welcome to the show today. This is the episode I call the Research Roundup. And it's because I'm not able to interview every single person, but I do read a lot. And there's a bunch to share with you about some of the latest studies in EMS. And that includes both pre-hospital and emergency medicine. So, hey, I'm your host. And today we have a packed episode. We're going to navigate a wide range of topics, from operational realities of our work on the streets and also in the air. And then we'll talk some about systems level challenges, technological advancements, and things that are changing in our field. All of these studies are super recent. And so let's get started. I want to talk about a topic that hits close to home for every provider, and it's our own well-being and the culture of our workplaces. A study in the International Journal of Environmental Research and Public Health came out called "Why Do Emergency Medical Services Employees Not Seek Organizational Help for Mental Health Support?" And it looked at why so many of us don't use the mental health services that our agencies might put out to offer us. And the findings point to a culture of machismo and sometimes stigma, along with a perception that support programs are more about organizational obligation instead of genuine care. The review suggests that for support to be effective, it needs to be person-centered. And organizations have to actively normalize its use. And that would be what creates a culture where asking for help is seen as a strength and not seen as a weakness. This cultural component directly impacts retention. You know, another paper in the International Journal of Environmental Research and Public Health came out called "Association Between Organizational Culture and EMS Clinician Turnover." They surveyed over 30,000 EMS clinicians, and it found that agencies with a hierarchy were able to be more rigid. Those top-down structures had a significantly higher rate of clinicians that intended to leave their jobs. And so in contrast, a clan kind of culture, which are more collaborative and supportive, were associated with better retention. So what that research highlights is this critical message for agency leadership that says, hey, building a supportive, team-oriented environment is not just nice to have. It's a core strategy for retaining a workforce. Right now, the professional landscape is evolving, and a qualitative study in the BMC Health Services Research journal called "Barriers to Paramedic Professionalism" came out as a qualitative inquiry across UK, Canada, Australia, USA, and the Republic of Ireland. And this found that common struggles across cultures are present in these developed healthcare systems. So paramedics are seeking recognition as integrated healthcare professionals, but at the same time face barriers like outdated legislation, inconsistent regulation, and the lack of funding and system integration problems. While the pandemic temporarily put a spotlight on our capabilities, that same momentum has faded. And so the study calls for a targeted policy reform and investment in education and leadership to solidify our role in the healthcare ecosystem. Another review that I wanted to share came out in Applied Ergonomics, and the title of the article was "Proliferating Paramedic Job Tasks, Injuries, and Physical Fitness." And it gives us this stark reminder of the physical toll of our work. The study confirms what many of us feel like in our bones, which is that musculoskeletal injuries, especially to the back, are completely rampant. This is something that comes from handling stretchers and patient extractions, and these are some of the most strenuous tasks. Interestingly, the review highlighted physical fitness differences, with male paramedics generally showing more strength but less flexibility than their female counterparts. And then older paramedics show declines in both. This data is crucial for developing targeted injury prevention programs and realistic physical standards to keep us safe and effective throughout our whole career. On the topic of physical attributes, there was a mannequin study in the Journal of Medicine called Rescuer Body Mass Index and Smoking Habits Affect Cardiopulmonary Resuscitation Quality. And this research study that was in medicine found that a lower body mass index was associated with suboptimal CPR quality. And then at the same time, height and weight also played a role. It's this fascinating look at how our own physical characteristics do influence patient care. Now, I want to shift our focus to patient care and start with some of the most critical calls that we run. And so we'll just begin with cardiac arrest. Study from resuscitation titled The Impact of Dispatcher Assisted CPR and Prior Bystander CPR Training on Neurological Outcomes in Out of Hospital Cardiac Arrest reinforces this immense value of bystander intervention. The study analyzed over 2,700 patients and found that any form of bystander CPR was better than none. But the results get more interesting because untrained bystanders who received dispatcher assistance had significantly better outcomes than those who didn't. And for bystanders who had already had CPR training, those outcomes were even better. So, especially when they acted without dispatcher assistance, and that suggests that their confidence and skill really paid off there. And the takeaway is clear. Dispatcher assisted CPR is a powerful tool. It's something that complements instead of just replaces the need for widespread public CPR education. So we need both. Once we're on scene, what we do matters immensely. And so a study in the Journal of Emergency Medicine called Should Anything Else Be Done Besides Prehospital CPR? The Role of CPR and Prehospital Interventions After Traumatic Cardiac Arrest. This was something that a research study that looked at adult traumatic cardiac arrest patients who received pre-hospital CPR. And while the overall prognosis isn't great, 30% of patients had a pulse upon arriving at the emergency room, and out of those, 35% survived. A key finding was that penetrating trauma and pre-hospital thoracostomy were independently associated with getting a pulse back. So this suggests that for certain traumatic cardiac arrest patients, it's just that aggressive interventions that aim at those reversible causes like tension pneumothorax can be life-saving. And that means that it has to be a consideration for us on scene. I want to talk about the resuscitation timing because I found an article in the International Emergency Nursing Journal called The Relationship Between Intervention and Transport Times in Prehospital Emergency Medical Services and Resuscitation Success. And what they did was retrospectively analyzed about 3,000 cardiac arrest cases, and it found that the average on-scene intervention time was about 18 minutes. And that's interesting because the study found that there was not a statistically significant difference in successful resuscitation outcomes based on the duration of on-scene intervention or transport times. So while this might seem counterintuitive, it also underscores that for witness cardiac arrest, our interventions are generally completed within about a 20-minute window. And a time frame often associated with better neurological outcomes for survivors is that kind of window. The specific rhythm during the arrest also tells a critical story. A post hoc analysis of the Prague out of hospital cardiac arrest study published in Critical Care Medicine under the title Cardiac Rhythm Conversions and the Outcome in Refractory Out of Hospital Cardiac Arrest This is something that provides some pretty fascinating insights. It confirmed that patients with an initial ventricular fibrillation rhythm who achieved and sustained ROSC had the best outcomes. But for patients with refractory VFib who only had an intermittent ROSC, then the invasive approach with early transport so that they could get to EPCR, also known to many as ECMO, that was more successful. So, what's the most sober finding? Well, the presence of a systole at any point during the resuscitation was a strong predictor of a poor outcome, regardless of the initial rhythm. Finally, on the pharmacology front, two studies in resuscitation looked at pre-hospital medications for the suspected acute cardiac patients. The first, pre-hospital antiplatelet therapy in patients with out-of-hospital cardiac arrest suspected of acute coronary syndrome. This is something that found that giving aspirin before hospital arrival did not improve a 30-day survival or reduce major adverse cardiac events in the out-of-hospital cardiac arrest patients. While it was found to be safe, it didn't seem to offer a clear benefit in this specific group. Similarly, a study in clinical research in cardiology was titled Pre-Hospital Admission of Heparin in Patients with Suspected Non-ST Segment Elevation, Acute Coronary Syndrome. This study questioned the routine use of pre-hospital heparin. So after comparing over 1,200 patients, the researchers found no significant difference in 30-day or 1 year mortality between those who received heparin in the field and those who didn't. So both studies suggested that we may need to refine our protocols and perhaps reserve these treatments pending further in-hospital assessment. Technology, particularly artificial intelligence and machine learning, is poised to revolutionize our field. We're seeing its application from dispatch all the way to diagnosis. And so let's start at the very beginning of a call. A study in the American Journal of Emergency Medicine titled Use of a Large Language Model for Ambulance Dispatch and Triage explored whether AI could prioritize ambulance requests. And so researchers gave ChatGPT groups of real-world dispatch requests and asked them to pick the highest priority patient. Then they compared the AI's choices to those of experienced paramedics. The AI agreed with the paramedic panel over 76% of the time. And even more impressively, when the human experts were unanimous in their decision, the AI agreed with them almost 94% of the time. So this is a powerful proof that these large language models could one day become a valuable tool for dispatch and in that way help allocate resources more effectively. Another innovative approach described in Traffic Injury Prevention Journal is this article called Prediction of Urban Medical Emergencies Using Machine Learning Models Based on Spatial and Temporal Variables. This is a study that used machine learning to forecast emergency occurrences. So by feeding a model data on location, weather, traffic, demographics, researchers in Colombia were able to identify periods with higher emergency volumes in a large volume area. While predicting this exact time and place of the emergency remains a challenge, this type of modeling could be a game changer for the system preparedness when it comes to things like resource deployment. Once on the scene, AI can also help us interpret our own findings. A study in academic emergency medicine called Words to Live By, using medic impressions to identify the need for pre-hospital life-saving interventions, analyzed the free text narratives written by flight medics. And so using a machine learning model, they were able to predict a patient's need for life-saving interventions like intubation or blood transfusion with good accuracy. And that was just from the words used in the initial impression. So words like unresponsive or hemorrhage. These are things that were highly predictive of for the technology. And this technology could one day be integrated, of course, with voice to text systems and do other things that would help us with real-time decision support based on our initial thoughts. On the hardwire side, a study in bioengineering titled Enhancing Trauma Care, Machine Learning Based Analysis for Estimating Blood Volume During Hemorrhage and Resuscitation shows some pretty incredible promise. So, researchers developed a machine learning model that could accurately estimate a patient's percentage of blood loss just by analyzing the waveform from a standard sensor. And so, the same one that comes out of our pulse oximetries. What's cool is that this could provide a non-invasive, real-time way to track hemorrhage and also guide resuscitation in the field. Obviously, that would be a major step forward in trauma care. We're seeing even new diagnostic possibilities. A study in medical engineering and physics titled Can We Identify Stroke Subtype Without Imaging? A Multidimensional Analysis is a study that explored a non-imaging approach to differentiate ischemic versus hemorrhagic strokes. And what they did was analyze 67 different parameters, including blood pressure, cerebral hemodynamics, and a model was able to distinguish between the two different types of stroke with high accuracy in a small group of patients. While it's early days right now, this points towards a future where we might be able to identify stroke subtypes in the field, and that is going to allow for more targeted care, right, from the moment that we arrive. So, also speaking of stroke, a feasibility study in PLOS1 called the Feasibility of Recording EEG in the Ambulance Using Portable Wireless EEG Recording System showed that it's possible to get adequate quality EEG recordings in a moving ambulance using simple forehead electrodes. And so this is another tool that we know is something that could help with pre-hospital stroke triage. A narrative review in the Archives of Academic Emergency Medicine entitled Current Applications, Challenges, and Future Directions of Artificial Intelligence in Emergency Medicine sums it all up. AI has potential to impact everything from triage and diagnosis to outcome prediction. But the authors caution that most of the research is retrospective. So we need, of course, more robust randomized controlled trials to truly understand the value of these tools in the chaotic reality of what we see in emergency medicine. Equity in care is a cornerstone of our profession, but several recent studies highlight concerning disparities in how emergency services are delivered. A major study in JAMA Network Open called Racial and Socioeconomical Disparities in California Ambulance Patient Offload Times analyzed nearly 6 million ambulance offloads in California. The findings were stark. The single factor most significantly associated with longer offload times was the proportion of Black residents in a community. And this represents tangible barriers to timely emergency care for entire communities. The disparities also were found in a study in JAMA Surgery called Racial and Ethnic Disparities in the Use of Helicopter Transport After Severe Trauma in the U.S. And it looked at over 340,000 severe trauma patients and found that Black and Asian patients were significantly less likely to be transported by helicopter as compared to white patients. This was particularly when folks were treated at level 1 trauma centers. This is important because the study also confirmed that helicopter transport was associated with a lower risk of mortality. An editorial in Resuscitation titled Disparities in Prehospital Critical Care Response, Further Understanding Potential Fractures in the Chain of Survival, comments on a UK study with similar themes. And that study found that patients in more affluent kind of neighborhoods were more likely to receive response from pre-hospital critical care team, especially a physician-led one for their area. And so it also found that female patients were less likely to receive that kind of robust response. These studies collectively paint a troubling picture because it reveals that we do have systemic biases that are present in some systems. It's also a call to action for us to continue to examine our systems for our biases that might prevent equitable care for every patient. Let's transition to some specific clinical challenges and operational topics that we face every day. Patient refusals are a high risk area for all of us. And an article in JACEP Open titled High Risk Patient Refusals in the Prehospital Setting, Clinical and Legal Considerations tackles this head on. It reminds us that when a patient with a suspected life-threatening condition refuses care, the legal and the medical risks skyrocket. And the authors strongly recommend that EMS systems develop standardized policies for these situations and also involve legal counsel. They advocate for using checklists, quick references, and having a low threshold to call for online medical control. And these aren't just calls to document well. They are complex procedures that require deliberate and robust kinds of quality improvement review. So what about managing agitated patients? Well, a retrospective study in the Annals of Emergency Medicine came out called A Comparison of Ketamine to Midazolam in the Management of Acute Behavioral Disturbance in the Out-of-Hospital Setting. This study compared these two common medicines, and in a cohort of nearly 400 patients, the study found no significance in the difference in the need for advanced airway management between patients who received ketamine and those who received midazolam. So rates of intubation in the emergency room and also mortality were similar. So this suggests that in this particular system, both medicines are viable options without one really posing a greater risk of respiratory compromise than the other. And then we ask, what about pain management? A nationwide registry study from Sweden was published in the Scandinavian Journal of Trauma under the title Pain Assessment and Management of Adult Patients in Swedish EMS. A nationwide registry study revealed some significant gaps. In over 394,000 EMS calls for pain-related conditions, pain intensity was only formally recorded in about 24% of the cases. And then analgesics were administered in just over 27%. So this points to a widespread lack of systemic pain assessment and management, putting many patients that might be at risk for suffering. We've covered a tremendous amount of ground today, from the culture at our stations and the physical demands of our job to the systematic inequalities that may be seen in patient care, and even talked about AI. We looked at interventions that happen in cardiac arrest, trauma, behavioral emergencies, and even questioned and talked about some longstanding practices. The common thread to all of this research is we really do strive to do better, to be safer, to be more effective, to be more efficient, and be more equitable. The findings that we discussed today have real-world implications for our protocols, our training, and for our use of data, and also how we advocate for our profession and for our patients.
Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research, or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch.
I want to also invite you to check out my latest book. I co-authored it with Four Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. if we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah. And
Right.
you think, well, maybe this is someone that can help. Well, you've said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chaplow from the International Prehospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for you to review on our website at iphmi.com and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference, whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes and Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.